Hello and welcome to another episode of Hema Now, our hematology podcast series. I'm your host, Dr. Jonathan Sackier, and in each episode I have the pleasure of speaking with leading voices in the field of hematology. Today I'm honored to be joined by Dr. Rafael Fonseca. Dr. Fonseca is a distinguished hematologist at Mayo Clinic, specialising in multiple myeloma and related plasma cell disorders. He earned his medical degree at Universidad Anáhuac in Mexico and went on to complete his residency in internal medicine at the University of Miami, followed by Hematology and Oncology fellowship at the Mayo Clinic in Rochester, Minnesota. Dr. Fonseca's research has been pivotal in advancing our understanding of the genetic basis of myeloma, drug development, and the treatment of myeloma-related bone disease. He's led clinical trials that have contributed to the approval of several new therapies. So stay with us as we explore Dr. Fonseca's career, his groundbreaking research in myeloma, and his insights on where the field is headed. It's a real privilege to welcome Dr. Rafael Fonseca to the podcast. Professor Rafael Fonseca, welcome to the podcast. Lovely to have you here.
Oh, thank you for having me. It's a pleasure to be here.
So from London to Scottsdale, Arizona, there's a little bit of a divide in the temperature, but having been to your amazing institution, it's a great place in a wonderful city in a great state. So tell us, Rafael, who or what was the spark that ignited your passion for medicine and your specialty?
Thank you. Well, I was just going to comment very briefly. The good news is we have a straight flight from Phoenix to London, so it's not as far now. So, I never thought I would be a doctor. And my life and my school years, I loved math, so I thought I was going to be something along the lines of an actuary or something like that. But it's not until I was age 17 when I suffered an accident that ended up with me staying in the hospital for about a week that I changed lanes, and that's where I decided to be a doctor.
Yeah, it's for me, it was having my appendix out, and when I was 11 years old, and I was so impressed with the surgeon who did that that I thought, yeah, I've got to do that.
There you
So,
go.
well, maybe we've got the answer to this one. If you weren't saving lives as a doctor, what alternate career path would you have taken? Would it still have been an actuary or
Well,
something?
I don't know. I still love math, although I found that my skills are rusty with age, even though I still try to engage on that. But I've actually always enjoyed a derivative of that, which is actually the field of economics. My standard answer has been that if I was forced not to be a doctor, because I probably would have to be forced not to be a doctor, I would want to be something along the lines of economy or the like.
Yeah, well, maybe we could have someone with actually a little bit of intellect running the biggest economy in the world. So you you may have some work to do. What's the most impactful piece of advice you've ever received on your journey to where you are now in your career?
Interestingly, it's the advice that I received as a child, and this came out because of my father's comments. And he told me, which I completely can expand on this in more detail, but he said, in life, time goes by whether you do things or you don't. So you might as well be doing things, which is now coined in others people's words as the action bias. And that's such a useful piece of advice. And if you marry that with curiosity, I think that's a winning formula.
Well, I know we're going to get along because my sort of byline is we spend a long time dead, and when I finish my podcast, I always finish with "Stay curious," because I think we're very lucky chaps to be doing what we do for a living. Um, if you had to sum up the future of hematology in just one word, what would it be?
Um, the future of hematology, in just one word, will be I'm going to be optimistic. I'm going to say contentment. And the reason I say that is because of all the progress we're seeing right now with what's happening with the delivery of an immunotherapy and targeted molecules. If I think about the immediate future, of course, we don't have the answers. But when I think years down the line, I think we will get to a point where, to some degree or another, we'll think of hematologic neoplasms like we think about most infectious diseases today.
Mhm. I think, based on my observation as an outsider throughout my career, the changes that you folks have brought to people diagnosed with these conditions is nothing short of phenomenal. And I've said this before, but I've been involved in a charity that provides for children diagnosed with what were fatal diseases. And I know when I started my work with that charity, these kids all died, and now they don't, which is thanks to people like you. So, in 10 seconds or less, what's a mind blowing fact about myeloma that most people don't know? Doesn't have to be 10 seconds.
Yes, thank you. One of the most elegant parts of our immune system is the ability of the human body and other organisms to generate antibodies that protect us from immunity. But the only way to do that is by having our B cells be constantly mutating. So I always tell patients perfectly healthy and happy young children have older cells mutating all the time just to self protect. It is a little hiccups there, a mistake that occurs there that ultimately leads to the cancer form of those B cells. But it is through mutation that we are protected from the challenges of the environment.
That's a nice way to look at it. I had another guest who was, we asked to explain leukemia in words a 5-year-old could understand. And I always say, I'm just a simple surgeon, so aim it at that level. If you could have a medical superpower, what would it be and why?
My superpower would be to get to a point, hopefully soon, that through some of the tools we have now, agentic AI, etc., that every single patient that seeks care for their condition gets the best there is out there. And we're far from there. I see quite a few patients in consultation or referrals that are seen by very competent and willing providers.
Oh,
But the body of knowledge of medicine has expanded to the point that it's impossible for any one human being to know everything there is about all cancers. So I think it's doable. I think it's achievable. Where not only because of the genetics, but because of the whole context of what the patient is, their personal situation, their social situation. Something along those lines could provide best tailored solutions for the person.
yeah, yeah, very, very much so. Um, So I tell you what, let's. These are great answers, and thank you for playing my game with me. Let's dive into some deeper topics, and let's start at the American Society of Hematology (ASH) 2024. You spoke on your findings from real-world data modeling evaluating the sequencing of CAR T cell therapy and standard of care in lenalidomide refractory multiple myeloma. Can you elaborate on the key takeaways from that analysis?
Absolutely. It goes without saying that the best and the purest results we can get in medicine is through prospective randomized phase 3 trials. The reality is we will never have enough of those trials to answer all the questions that we need answers for in medicine. So we've taken the approach of using this very large data set, the so-called real-world evidence, to try to address some of the most pressing questions. One of those questions right now is: should we use CAR T as the first relapse treatment, or should we delay that until a later point? Absent those phase 3 randomized prospective trials, the best source is real world evidence. We have incredible results now with studies like CARTITUDE-4 that have compared CAR Ts versus standard of care for patients who are experiencing a relapse and who have only 1 to 3 prior lines of therapy. And we already show improvements not only in progression free, but also in overall survival. But what better than to validate that through data sets that already indirectly are addressing this question? And I'm happy to say that I think we've moved to a point where people saw real world evidence at the beginning with some skepticism. But as that has permeated through every single aspect of human life, we know that it can provide good approximations to some of these questions.
I guess there's other issues with trials, aren't there? I mean, there's the classic paper in, I think the oh, was it the BMJ, the British Medical Journal, about the fact that the use of parachutes has never been demonstrated in a prospective randomized double-blind controlled trial to actually prevent gravitationally induced injury. And it's a rather ironic look at a fact that you can't always do those trials. Those trials are expensive and lengthy. And we sometimes have to evaluate the best evidence available at a given point in time. Is there a lot of pushback from purists about the use of real world data?
There has been. I think it's subsided a bit. I'm grateful for that pushback because those are the checks and balances that we have in our system. But the stark reality, as I mentioned before, there will never be enough clinical trials. So I myself have been involved in cooperative group trials that are sponsored through the NCI in the United States industry-sponsored trials, institutional trials, and no matter how much energy I would put behind those, I would never have enough information to answer the questions I face at the bedside. So no matter what, at the end of the day, the clinician, the surgeon that's dealing with a patient situation has to make a judgment call, and part of that could come out of this information that comes from real world evidence. I would
Sure.
say 5 years ago, the rooms were, not very populated when you had presentations like this at the meeting like ASH. This last ASH meeting, it has to be a very large room and there's not an open seat because people realize the power of the answers that are coming from this very large data sets.
Yeah. Wonderful change in mindset. So, at the 19th International Workshop on multiple myeloma, you spoke on a roundtable discussion about clinical trial updates in myeloma. Can you highlight the key takeaways from the latest developments in anti CD38 monoclonal antibodies, antibody drug conjugates, bispecific antibodies, BITES, I think,
Yes,
and minimal residual disease treatment in decision making? Big question. The floor is yours.
I know that's going to take me half an hour. I'll do it very succinct. And just parenthetically, I think the term BITE is a proprietary term referred to smaller molecules that are produced by Amgen. But so in general, I'll just talk about the bispecific antibodies. First
Okay.
of all, CD38. CD38 are quote unquote naked antibodies that target the CD38 molecule on the surface of plasma cells. And there is no question they have revolutionized our ability to provide effective myeloma control. We've seen that in two settings recently, and both of them are in the frontline therapy. That is for patients who are going to undergo a stem cell transplant, and then for patients who we would normally deem not eligible for stem cell transplantation. In both cases, these antibodies have greatly improved our ability to control the disease. To give you an idea, when we started doing treatments in the past, perhaps combining two or three drugs and putting a patient through a stem cell transplant, we would get to this very deep level of response that you alluded to, the minimal residual disease, perhaps in about 25-30% of cases. With today's combinations, including those that have those type of antibodies, it should be expected that about 80% of patients can become negative at this level of minimal residual disease negativity. So this has translated into long-term outcomes. One of this is exemplified by the clinical trial Perseus. Perseus at 4 years has a progression-free survival of approximately 85%. And it has been estimated now, and this is of course fraught with some challenges and the need for additional follow-up, that if you were statistically to project what the median time is going to be for PFS, it could be as long as 17 years. So this completely changes how we think about myeloma and what effect it might have or not in limiting a person's lifespan. And the same is true for people who get the same combination but don't get a transplant. The durability of these treatments is the best. Some of these trials show that at 5 years, 20% or less of patients have required a change of therapy. So more and more, I'm encouraged by the notion that A, I think some myeloma patients are being cured, and B, even for some of those that are not cured, I think they can more and more approximate a normal lifespan. Now, I did mention briefly MRD. MRD is measurable or minimal residual disease. Just refers to the tools we use now to seek for very rare remaining cells after a period of therapy. This can be done both by flow cytometry as well as by DNA sequencing. And as I mentioned, we can have a large proportion of patients getting to that negativity. And the good news is this is really harbinger of what's going to come down later because all the studies show if you get to deep MRD and doing so safely results in more durable disease control. So it's something we routinely now use in our clinical practice. And as you can imagine, when we talk to patients, I tell them I have a test that can find if there's a cell out of a million cells that we test. In fact, just yesterday, I gave one of those reports to one of my patients, and I find that myeloma patients are particularly well educated and engaged, and they really love to see what we're talking about when we measure this MRD. Now, there were two other topics you asked me about. One of them would be the bispecific antibodies.
Yes.
An incredibly smart solution. To patients, I describe it like they're like double-sided Velcros or the matchmaker. So the medication version of CAR Ts by inducing the induction, of course, of cytotoxicity by those T cells against those myeloma cells. And we know they're very, very active. But at this ASH meeting, and we saw some of that also at the IMS meeting, we started seeing what the results are if you put them as part of frontline therapy. Who would have thought that? There were two European presentations, one that looked at bispecifics as part of induction therapy, and another one that looked at bispecifics as part of consolidation. And they showed very few patients, 20 patients, but they showed 100% MRD negativity rate. So, it wouldn't take a lot of creativity to think this will be part of frontline therapy for myeloma at some point. And lastly, you asked me about ADCs. The most notable of this is belantamab mafodotin. Belantamab was a drug we had for some time approved here in the United States and had to be withdrawn from the market because a confirmatory study was negative. But truly, kudos to the company. They did the courageous trial. So they compared, for instance, belantamab mafodotin versus one of the standard of cares that contains daratumumab. And the study came out being positive. These are the Dream 7 and the Dream 8 clinical trial. So there is an expectation that they will come back into the market. They were just recently approved by the EMA. So I think we'll see similar an approval by the FDA, and we'll start the head scratching just to know how we're going to sequence all these treatments for our patients.
Yeah, that's the key thing, isn't it? Which drug do you put first? And there's this philosophy, and I know cost always plays a role in this, that if you've got a powerful new drug, do you hold it back for a recurrence or do you hit the disease hard up front? How do you do those sort of trials? That must be an intellectual challenge.
It is very hard. And let me use an example that we have also from real world evidence. We wanted to ask the question, okay, if a patient completes a line of therapy, how likely it is that they're going to complete the subsequent one? So we actually took a hold of one of those data sets, and we could start with very large numbers. For instance, for patients who are not transplant eligible, we had 22,000 patients. And what we found is that, and this has been replicated now by at least five other studies, that somewhere between 25 and 50% of patients don't get to complete their next line of therapy. So we use that now as an argument to say, sure,
Why don't they complete? Because they
there's a combination of progression, death, complications. Sometimes it's because they're doing very good, and sometimes because they are lost to follow up,
yeah,
which
okay,
matters because all of the series, have been done in different health systems.
sure.
And what we have learned is no matter how you define that, there is a significant fraction of patients that are lost. There was a paper that just published, I believe, a couple of weeks ago that shows that it's less in the recent years, and that probably reflects safer, more effective, and better tolerated treatment. So that's very good news. But back to the point, you cannot assume there is a future for a patient where they might be able to get the better drug. So I've used this as a point to say, like sports players, the better ones have to go to the first division. So as we have these treatments that are showing these wonderful responses, it makes more sense for their earlier use. The bigger challenge now is that some of them share the same target. Great example for this is BCMA. So if you use a BCMA targeting agent and then later you want to use a CAR T, you can, but the return on investment, meaning on efficacy and durability of disease control, is less. So I don't know the specific answer to the question. We'll need some mathematical modeling to say if you start with this and you have this number of months of control, and then you assume X rate of attrition, which is the loss, of course, between the lines of therapy, then this might be our projection. Now, running this in a prospective fashion and doing clinical trials that will have one treatment and a second and maybe even a third, it seems nearly impossible right now, given the durability of some of our therapies for frontline.
Thank you for that. So with the ASCO conference, the 2025 ASCO conference approaching, are there some particular sessions or trial results that you're really looking forward to seeing?
Yes, there are three of them that caught my eye. Probably the most talked about is the long-term outcomes for patients treated with cilta-cel, which is one of the BCMA targeting CAR Ts. This was in the CARTITUDE-1 clinical trial. These were myeloma patients who had received a median of 6 prior lines of therapy, so pretty advanced in their treatment course. And for as a reminder, CAR T's one and done. So it's one treatment, they complete the treatment, and at 5 years, they have 30% of patients without any evidence of recurrence or progression. I want to see those details because that might mean that, in fact, for some patients, for some myeloma patients, CAR Ts could become curative. Now, we have an approval to use CAR Ts earlier. This came out of CARTITUDE-4 that looked at patients with 1 to 3 prior lines of therapy. So we can use it earlier in the course of the disease now. And one could only imagine that the results are going to be better then. So eagerly awaiting that particular presentation. There's an early one of new tri-specific antibodies. So, bispecifics are good. What about tri-specifics? And the results appear to be quite promising. So it's GPRC5D and BCMA targeting. And the third one that I'm particularly interested in is a follow-up on a study called MIDAS. This is a study for frontline therapy, again, with quad regimens, including CD38 targeting antibodies. In this case, it's atoximab, where they seem to be reporting some of the best results regarding MRD. But the study is also addressing an important question. If you become MRD negative, do you still need a stem cell transplant? I don't think we have the answer yet, probably not anytime soon. My hope is, of course, that there's a future without high dose chemotherapy as in transplant. But as of now, I still think it's an important tool, but I would love to see these trials become positive.
Okay, well, we'll have to have you back on after ASCO so you can tell us what you thought and how it's changed your practice and expectations for patients. Your lab, Rafael, has made groundbreaking contributions to the genetics of multiple myeloma, including identifying key subtypes and genetic abnormalities. How do you see discoveries, particularly in understanding subclones, influencing personalized treatment strategies for myeloma patients going forwards?
Thank you. Yes, I think that's one of our most cited papers in collaboration with my colleagues here. We published that paper on the existence of subclones. I always like to remind the audience when I'm speaking about those subclones. So these are subpopulations that have certain genetic differences that we can detect at the single cell level. We started actually doing this with simple fish analysis, but we can find there's different populations. But at the same time, these clones are nearly identical to each other. So they share some features that never change. For instance, if a myeloma patient has a 414, every single cell of the myeloma population of that patient will be 414. And also, every single cell of that patient, myeloma cell population, will have the same B cell receptor. That I use the analogy, that's like the soul of the cell. The subclones are the secondary changes that occur. And this is a little bit like that game of find the differences between two pictures. They're nearly identical, but yet they're different. But the knowledge that came out from the subclones was that they wax and wane depending on which treatments you're using, and this should be not surprising. It's evolution principles. So for us to be effective and getting to the point that we can fully eradicate myeloma, we have to cover every single subclone. Because when we did that study, we were using single agents. So oftentimes it was lenalidomide, and then the patient came off, and then it was carfilzomib. And my colleague Keith Stewart came up even with a concept of the clonal tides, where you see some clones go up and some clones go down. But we don't want the tides. We want all clones to be gone. So that's kind of that combined with attrition are two key principles that we use now as we design the treatment for patients, particularly frontline therapy.
So, a more philosophic question for you, Rafael. Certainly during my professional career, it's become harder to do research. And it's become harder for clinicians to do research. Money is in short supply. The complexities of doing work have certainly grown. And your work spans both discovery, scientific discovery, and clinical application. How do you see that gap between laboratory research and patient care? How do you see the gap? What can we do to narrow the gap, which inevitably will lead to expediting bringing new treatments to the patients who can benefit?
Well, that's a tough question. I would have normally said a great question, but I would call it a tough question because
Good. I'm glad. That's my job.
aha. So I'm a big fan of translational research, and I feel very fortunate to have one foot in the lab and one in the clinic, because everything we're doing in the clinic can relate to what I'm thinking of what we're doing in the lab, and vice versa. And it is not an exaggeration. It's not a saying that it's bed to bedside, bench to bedside, I'm back, and that is true. I think when you ask that question with the idea of, okay, that's bringing molecules, that happens, but that's less common. But even just the understanding of every patient's unique situation. But you're right. I mean, the resources are scant. you can never have enough money because you would just need an inordinate amount of money to run all the clinical trials you would want. You might even not have enough patients to actually do the trials. I think our responsibility is to maximize the opportunity for that research through the enrollment in those trials for those that are eligible, also through the study of our patients. So one of the things we take great pride in is we collect samples pretty much on every single patient that we see in the clinic. Of course, this is a voluntary process. The patient care is never affected if they decide not to do it. But we have an IRB approved protocol by which samples are collected routinely. We have now thousands of samples. And with that, then we start putting layers of questions. Okay, what does this mean for genetics? What does this mean for MRD? Let's report on the series with this or that other feature. And I think indirectly that has helped us advance quite a bit our understanding of the disease. And then obviously that leads to guidance as to how to best treat therapy. It is also marked by our own unique slant of philosophy. And it's not that one holds the truth, right? But some people are probably more nihilistic or more reserved in how they want to approach what they're doing. I personally like to be more proactive and I again, I don't claim to be that's the right thing, but to me, the indicators are there indirectly through the concatenation of all this information that for us to advance, we have to understand the disease, but also eradicate all those clones.
Okay, well, my final question, if you thought that was tough, here's a tougher one. Um, I like to ask guests that if there was a magical genie who could give them 3 wishes for their area of healthcare, what might they wish for? That's your question for today, your final question.
3 wishes for my area of healthcare. I think so I'm going to focus it on myeloma exclusively, just not to make it broader. I think the first one would be to have limited duration of therapy, and it's limited because it's effective and it's final. So if I could have this genie tell me, you have a treatment, I'm going to take it to an extreme, like, hairy cell leukemia, where you treat with 5 days and most patients are cured. If I have a treatment, maybe a CAR T that can be done once, and then the myeloma patient does not have to be a patient again, that would be number one for my wish. Uh, my second one would be, okay, this is one that just came to mind. My second one would be, I would love to see all of the knowledge that we have garnered and generated in the fight against cancer cells that produce antibodies being used in the fight of human diseases that are serious, that are driven by antibodies. This is one of the things that I'm very interested in, because at the end of the day, you think about serious lupus, rheumatoid arthritis. There's so many autoimmune conditions that are life limiting or significantly decrease the quality of life of patients. And we do have the tool to get rid of those plasma cells. I use an acronym for that, which is a KPC, kill the plasma cells. And I think we can do that. So, and there's some traction in that area. So I think that's my second one. And my third one would be the last one. I would love for everyone, wherever you are, not only to have access to the treatments, but also have access to the knowledge that positions you to maximize the benefit. I think Genie number one could have given me the answer for 5 days. But if patients cannot get that 5-day treatment, then it's incomplete. And I would love for that to happen.
Yeah, lovely. Well, you're going to have to come back and talk to us after ASCO and let us know what you learned. But thank you for being with us here today, Professor Rafael Fonseca. Fascinating talking to you. This British surgeon will be going to bed less dumb tonight because of your wisdom and your very clearly articulated answers. Thank you, sir.
No, thank you very much. I appreciate it. I always love the self-deprecating humor of my surgical colleagues, but we have a lot to learn from each other. So thank you very much for the opportunity, and it was a pleasure.
Well, I hope you enjoyed that episode of Hema Now, our bi-weekly podcast on hematology. Please consider subscribing on either Apple Podcasts or Spotify, or frankly, wherever you get your podcasts, so that you never miss an episode. Like us on social media, tell your friends and colleagues, and please check out the archives because they're growing if you've missed any episodes. And please join us again in 2 weeks for another episode. Until then, I'm Dr. Jonathan Sackier. I'm proud to be your host. Please, everyone, stay safe, stay well, stay curious. Bye for now.